Good evening, and it's very good to welcome you to the 2023 iteration of Best of Digestive Diseases Week in Inflammatory Bowel Disease. And this webinar, my name is James Lindsay. I'm a consultant gastroenterologist at Barts in London, and I'm joined tonight, as ever, by Peter Irving, also a gastroenterologist at Guy's St Thomas's. This, as many of you who would have joined before will know, is an educational activity that is sponsored by pharma companies through educational grants. And we are absolutely delighted and very grateful to AbbVie, Bristol Myers Squibb, Celltrion Healthcare, Galapagos Biotech, Pfizer, and Takeda UK, who have generously supported this program. Really key to mention that sponsors do not have any input into the content of the program. So again, many of you will have been to one of these before, and I won't spend ages discussing how we come to the program, but it is a bit of a process, and it's worth understanding the process. Effectively, before Digestive Diseases Week, which this year was in Chicago, the faculty and fellows go through every single abstract title that is related to inflammatory bowel disease that's being presented at DDW, and then divide them into the broad categories which are going to make up the sections that we cover. Then just before DDW, we meet and we run through each of the categories and decide what are likely to be the most impactful presentations. Then we divide up into teams, fellows and faculty, go to those presentations or posters, ask questions, and try and clarify any points that are not clear. The fellows then do an amazing job of putting together the slides for each of the presentations that are thought to be the best of their particular section. And then the day after DDW, we meet as a group, the faculty and the fellows, and we debate which of the abstracts seem to make the most impact on our practice. And that's how the Best of DDW slide set, which is then formatted by the fellows with some support of the Cornerstones office, that's how the Best of DDW slide set is developed. Peter and I then select a subset. There's probably about 110 abstracts in total in the Best of DDW slide set. And we select for the sort of 80-minute webinar that we're going to do now, we select perhaps the 50 or 40 that we think are most relevant to UK practice. And they always include some mechanistic sort of etiology type stuff, a chunk of treatment, and then some adverse effects and patient monitoring. And we try and avoid some of the sort of big US database trawl type studies that perhaps have less relevance to a UK audience. Obviously, the faculty, here they are. You can see they come from the UK. That's Pete and me. The directors of the course are Marla Dubinsky and David Rubin. There's a US predominant faculty, but also increasing faculty from Asia Pacific, Australia, New Zealand, and recently Israel. And then we are supported by some amazing fellows who put a lot of work into developing the slides. You can see them here, and a big shout out obviously to the UK fellows, and that was Jenny from Guy's and St Thomas's and Josh from Barts, and here they are. And just to highlight, Josh is there in the blue shirt, and Jenny is right at the back. You can, just over there, just over Josh's right shoulder. Yeah. And so we're very grateful for the work that they've put into that. And then these are the topics. So as I say, there tends to be a little bit of a focus on treatment because that's perhaps the most relevant to our practice. But we do start with some natural history and epidemiology and move on to some of the other aspects if we have time. So I'm going to hand over to Pete, who's got the first couple of abstracts.
Just one, actually, if I remember rightly, but still, I'm just going to hide that. That's all right to press that, isn't it? Yeah. Okay, so we're going to start off with the GEM study, which we've seen a little bit from before. It's been going on for about 15 years now, first recruiting in 2008, and is a study that's now recruited over 5,000 healthy first-degree relatives of individuals affected with Crohn's disease. And if you look at the little schematic on the right there, what they're trying to do is identify those patients who go on to develop disease themselves, the first-degree relatives of the patients with Crohn's. And they're really GEM looking at genetic, environmental exposures and microbial factors that may predispose to Crohn's disease, although in fact it's spanned out into some other areas too. No, you're right, it's too abstract. I'm going to pick 2 of the 4 that were chosen. Let's start with number 1, which I thought was interesting. And this related to exposure to parental Crohn's disease in the perinatal period. So what they meant by that is whether your mum had Crohn's disease when you were in utero or within the first year of delivery. So it's a period of about a year and 3/4. And what they found is that if your mum had Crohn's disease during that time, then you were about 5 times more likely to develop Crohn's disease than if your mum hadn't been diagnosed with Crohn's disease at that time. So there wasn't any measurement of disease activity here because, of course, that's very difficult to assess retrospectively. The other nice control they did here, because one might think, okay, well, if your mum had Crohn's, then basically this is a marker for early diagnosis. But they also did it for fathers. It didn't matter if your father had Crohn's disease during that time. So there must be something else, another exposure. And I think the obvious one, to my mind, would be the microbiome.
Yeah, and I was going to ask that question about early onset. Is this just a surrogate for if you develop the disease early, you're more likely to your children are more likely to have it? But as you say, with the fathers, not. And of course, the meconium study is looking at exactly that, which is the impact of maternal microbiome on subsequent fetal risk of developing Crohn's disease for mothers that have Crohn's when they are pregnant.
And there's one that's doing fecal transplantation?
That's no, meconium is a cohort study from Mount Sinai.
But there is one, isn't it? I think I'm not sure. I may have made that up. I don't know, but it's the logical follow-on, isn't it? I think there is, but anyway, I might be wrong. And then I'm going to pick study number 3 as well, and this is about having more than one first-degree relative with Crohn's disease, and whether that increases your risk of developing Crohn's. And I think logically you'd say yes, wouldn't you? Because you'd think, okay, well, if I've got more than one first-degree relative, then clearly I'm going to have a higher genetic load, if you like. But actually,
or more at risk of environmental burden, I guess, from your family.
Maybe.
Maybe yes.
Maybe not. Don't know, because I would think family environment wouldn't change. Maybe not. Interesting. Not thought about that. But what they did is a polygenic risk score, and that's really looking at genetic load, I guess, is the way that I would try to explain that. And in fact, they showed that whilst having multiplex, being from a multiplex family, in other words, more than one first-degree relative with Crohn's, was an increased risk. It wasn't related to genetic load. So that 3-fold increase of risk of developing Crohn's if you're in a multiplex family wasn't represented by a higher genetic load than in the patients in the simplex family. So I don't have a particularly obvious answer to why that would be, unless it relates to genes that are somehow more important in multiplex families. That, you know, and genetic load is probably a difficult thing to define. Anyway, two fascinating presentations for a fantastic study. I'm going to skip diet because James is going to talk about diet now and the problems associated with that. I'm going to skip the metabolite one because I always find those a little bit difficult, and I always wonder if they relate to pre-diagnostic exposures rather than true differences. So James, back to you.
Yeah, I'm going to talk about diet, but I am actually just going to bring up one dietary methodology thing that I think comes out from number 2. And this is looking effectively at the 78 people out of those 1,500, after those 5,000 who were healthy relatives who were recruited, the 78 who subsequently developed Crohn's disease, for whom they had good quality food frequency questionnaires, and then they matched them for affected relative age, etc., to 311 controls. They looked at baseline diet, so diet at the time of enrollment, therefore a considerable time before the people who did developed Crohn's, and looked to see whether there were any dietary patterns associated with the development. And you can see here they felt that docosahexaenoic acid, alcohol, and aspartame had the highest number of associations with Crohn's disease associated metabolites. And I guess what I'm drawing out
You're
here
doing the whole abstract.
No, well, I'm drawing out here the fact that you have to be really, really careful about how you interpret food frequency questionnaires. This has gone down to saying that you can, from a food frequency questionnaire, derive data on absolute dietary intake of individual nutrients. And I think perhaps most food frequency questionnaires simply don't contain that granularity. And I'm going to go on to two other dietary studies now, because there were so many that were presented. The first comes from Mireya Abruz's group in Miami, and the reason I really liked it is because for the first time this tried to get on top of the impact of dietary components that were relevant to different ethnicities. So traditionally we use a sort of UK-based food frequency questionnaire, which is great for Caucasians or people who follow a standard UK-based diet. But if for example you follow a particularly an Asian diet or a South Asian diet, actually our food frequency questionnaires may not capture the granularity, may not capture the food group. So what the team in Miami did was to try and look at the very important ethnic groups within their area, and those Hispanics and Cubans, and they developed a food frequency questionnaire specific to the diet commonly taken by Hispanics and Cubans, and then they did this at baseline, and then they followed patients who were in remission at baseline. They followed them over time, looking to see which aspects of a traditional Hispanic diet were associated with either IBD, UC, or Crohn's flare. And they used an unsupervised machine learning clustered technique in order to try and capture within the diet what food groups clustered together in terms of consumption. They recruited just over 200 patients. You can see the split, majority UC, and about a third had a flare during the year's follow-up. And what you can see is cluster 4, which is the purple, was associated with a lower risk of disease flare in this Hispanic population, and cluster 4 was particularly starchy vegetables and tropical fruits. Now, of course, what this is just an association, and of course, you know, it may be that patients with subclinically active disease who are more likely to flare avoid starchy vegetables and tropical fruits, and that may very well be the case. This is an association, not a causal study. And then on the right, we have the first data coming out of the PREDICT study, and it's really exciting to see this. This was over 2,000 patients, again, with IBD in clinical remission. And this cut is looking at the just over 1,000 patients recruited from over 49 centers, in whom they had all the relevant food frequency questionnaire type data, in order to be able to look to see what habitual diet was. And then obviously this trial followed people up over time, and it defined 2 types of flare. There were soft flares, which was effectively a patient reported flare, but what we're focusing on here are what they called hard flares, and they were patients who after baseline had a increase in symptoms as measured by one of the disease activity indices that we use, associated with an objective marker of inflammation, a CRP or a calprotectin. So these were definite flares. And what they found, if you looked at baseline and then followed people up over time, what they found is that about 5% of the patients recruited had one of these hard flares each year, and that, as you might predict, baseline calprotectin predicted those who were more likely to have a flare. So that was true for calpro of greater than 250, but interestingly also true for a much much more nuanced calprotectin window of between 50 and 250. So even a subtle increase in calprotectin predicted patients who were more likely to flare during the subsequent aspect of the trial. And then from the dietary perspective, what you can see in the graph is the patients split by their meat intake into those with the lowest meat intake in red to those with the highest meat intake at the bottom there in a sort of bluey color. And what you can see is if you eat if you're in the lowest quartile of meat intake, you are less likely to flare. And the sort of clinically relevant low meat intake was 25 grams, which is about half a chicken breast. So from this, there's an association. Again, important to stress, it's not causal. There is an association between low meat intake and risk of flare.
Can we just go back? They're not quartiles by meat intake, are they? But are they quartiles as in? You can see what I mean. Right. It's 0 to 25. I don't know if that's a representation of how much meat one eats.
No, I divided by that. No, it's not. It's not quartiles in the absolute meat intake. I suspect what it is quartiles of the population, and then looking at the meat intake. Because obviously, 331 grams is therefore quite a lot of meat. If 25 grams is half a chicken breast, that's the majority of several chickens.
Right. It's a big chunk of prime rib. So and methodologically, putting meat and fish together as a dietary component when you're looking at flare, I would not claim to have any expertise here, but we've always thought of oily fish as more likely to be protected.
Well, certainly, and yeah, I mean, obviously there was some data from the EPIC trials looking to show oily or the relevant fatty acids, fishy fatty acids being protective. And I don't know the rationale behind this, because I suspect from a food frequency questionnaire you would be able to divide meat intake from fish intake.
So are you going to tell your patients to go veggie?
No. I mean, not yet. Not because I don't. I mean, not because it may be, and there has been other data suggesting that low red meat intake is certainly associated with a lower risk of flare in ulcerative colitis. But again, this is an association, not necessarily a causal relationship. And of course, what you don't know is whether people who eat less meat also do some other dietary intervention that is actually the causal variant. And so one has to be a little bit careful about making practice-based interventions without some form of clinical trial that assesses that properly, which of course has to be appropriately controlled and blinded.
And very difficult to do.
But again, so just reminding people, if you want just to tap in your questions into the question tab, and we're going to move on into the next section, which are small molecules. And I'm going to start that. And we're going to start with some data from upadacitinib, and this is some of the Crohn's data. There were a wealth of upadacitinib abstracts presented, and we've certainly not got time to go through all of them, but I'm just going to run through some of the Crohn's abstracts, and in order to do that, I'm just going to run through the clinical trial design. There were two induction trials, UExcel and UExceed, and both of these were placebo-controlled, 45 milligram once daily for 12 weeks versus placebo. And UExcel included both bio-naive and bio-exposed, and UExceed only excluded bio-exposed. And so there was a predominant bio-exposed or people who previously lost response to biologic therapy within the induction and therefore also the maintenance trials. If you met the target for clinical response, that's detailed there, you were randomized into the maintenance arm, where you were randomized 1:1:1 to receive either 30 milligram of upadacitinib, 15 milligram of upadacitinib, or drug withdrawal to placebo, and then followed up over the course of another 52 weeks. If you did not meet that definition of clinical response, you were able to have effectively an extended induction period, but that extended induction period was at a dose of 30 milligrams. There was nobody who continued upadacitinib for longer than the 12 weeks. Importantly, and unlike many many or almost all previous induction trials, there was a forced steroid taper commencing from week 4 of induction. So people didn't stay on the same dose of steroids throughout induction. They had a forced steroid taper, and I think that's one of the strengths of this study. So the first, the top here is looking at the data for some of the endoscopic endpoints, and that's the top section of this slide here. And you can see on the left, we've got the induction trials, and we're splitting the endoscopic data between patients with and patients without previous biologic failure. So on the left of each of the sections, you've got the bio-naive, and on the right, the bio-exposed. And I hope what you can see is that looking at endoscopic response or endoscopic remission, that you get a strong signal of benefit of the drug above placebo. Now, numerically, the benefit is lower in the previously biologic exposed, but if you look at the delta, it's 30.5 compared to 35, 25 compared to 16. So you do get quite a strong maintenance of benefit. And then if we come across here, and I think there are some important messages here, if we come across now to the maintenance arm, so in this, obviously, there were 2 different doses versus placebo. And again, you look on the left of each chart at the bio-naive, endoscopic response, endoscopic remission, and on the right of the graph with prior bio failure. What you can see is that the benefit of the 30 milligram dose really stands out in patients who've previously failed biologic therapy. And whereas there isn't so much in the difference between the delta for the 15 and the 30 in the bio-naive population, when you get to the bio-exposed population, you've got a delta of 19. So that's a difference above placebo of 19% in the 15 milligram compared to 35% in the 30 milligram, and obviously numerically less, but similar differences in the endoscopic remission. So I think that tells us a message, which is that in patients with previous biologic exposure, certainly initially, you should probably go down to 30 milligrams first of all.
So one of the messages that I know both you and I were slightly surprised at DDW was there were a couple of fairly well-known Americans who stood up on stage and said, well, you should only ever use the highest maintenance dose for hepatocytinib and tofacitinib. So you should only ever use 30 BD and 10 BD for UPA and TOFA respectively, which is not what the label suggests, but that they were saying it's pointless going to the lower dose.
No, I don't agree with that. And I don't agree with that for several reasons. Firstly, the clinical trial data definitively shows a significant benefit of 15 milligram over placebo in some patients. Now, in the more refractory patients, which we're seeing here as the bio-exposed, in the patients, and we saw that from a previous Best of DDW presentation last year, in patients with extraintestinal manifestations or significant anemia, the benefit of 30 milligram maintenance is higher, and you might choose to do that. But of course, the risks are also higher, and there may be patients in whom you decide that you want to minimize the risk by reducing the dose. I mean, I think one of the issues is that within the American clinical practice, JAK inhibitors have always been historically right at the end of their clinical or their therapeutic strategy, and it's been sort of reserved for patients who've failed all else, and that's because of the black box warning that was on and of course those are these bio-failing patients who seem to benefit. Whereas in our practice, where we use them certainly in ulcerative colitis, but also in Crohn's disease slightly earlier, then I think there will be patients who can get away with 15, and certainly from a safety perspective, that's more attractive.
It's a somewhat unthinking approach,
yeah,
and it belies the subtlety of IBD management. So yeah, not a popular message as far as I'm concerned.
And then the bottom is now looking at this slightly unusual extended induction treatment. So these were patients who received 45 milligram of upadacitinib for 12 weeks, did not meet the criteria of response, which I think was about a 30% fall in patient-reported outcomes, and then went on to receive an additional 12 weeks of 30 milligram mandated 30 milligram treatment. And you can see then at the end of that 24 weeks, so that's 12 weeks at 45 and 12 weeks at 30 milligrams, you are reaching a response in upwards of 50%, remission in about a quarter of patients. So I guess, I mean, that sort of says that, you know, maybe you shouldn't give up at week 12, although I have to say, by the time you've done 12 weeks of treatment, if someone hasn't had I guess it means you shouldn't give up if they've had some benefit, but not gone all the way into remission.
So that's the point, okay? And people often miss this because, of course, clinical trials define response based on something agreed with the FDA and the EMA as a definition of response. That's not how we do things clinically. No one should be carrying on treatment after 12 weeks if you've had no response at all. It's if you've had a partial response, then think about continuing at the induction dose. But that actually doesn't even apply here because it's not continuing it. It's a a quirk of the trial design.
And the reason is not to keep people on that 45 milligram dose for more than 12 weeks. But I guess it says that if you've had a response but only a partial response, you should be going to the 30 milligram dose.
Don't go down to 15.
Okay, so just maybe a lot of time spent on that, just maybe slightly quicker look. One of the real interests has been, do the new small molecules have an impact on perianal fistulae? Now, the trials we've just discussed didn't have a perianal fistula healing as a pre-specified endpoint, and certainly patients weren't randomized, stratified on the presence or absence of perianal fistulae. But they did, within the whole trial program, have 140 odd patients with fistulae, the majority perianal. And you can see here in the red and grey the endpoints in the induction, and then in the blue and grey in the maintenance. And don't forget, these patients were assessed based upon their disease activity as to whether they went into the maintenance, not upon their fistula response. But what you can see, if you look here at external closure of fistula openings, complete resolution of draining, or greater than 50% resolution of draining, again, a clear signal of benefit of drug over placebo, and that, as you might expect, also correlated with the clinical and endoscopic appearances that the main clinical trials were designed to show. And then if you again look to see whether those results are maintained, again, you see that in those patients who withdrew drug and went on to placebo, all patients had recurrence of their perianal fistula, because there was a 0 for all the endpoints, but there was maintenance of that benefit in some patients. And I don't think I would take this as being clear evidence that we should be using this as the primary treatment for perianal fistulizing disease, because, you know, there's only really been infliximab for which a dedicated trial has been looked at. But I guess it means that you shouldn't be necessarily excluding patients for whom you're treating their intestinal disease, but they also have a perianal fistula, because there is a chance it might heal.
There's a placebo-controlled ustekinumab trial that's just finishing now, which should be out soon. Jet-aid. And clearly what's needed here is a trial that looks at UPA in fistulizing disease.
I mean, there was a trial with forgotten, it wasn't there?
But they couldn't recruit.
And so now we're looking at the impact of UPA in both Crohn's and ulcerative colitis on some of the very important patient-reported outcomes, and that's looking at quality of life as measured with the IBD crew response and remission, and the SF36 response and remission, and also looking at the impact of drug on fatigue as measured by the FACIT-F, one of the validated fatigue scores. Bottom left here, we have the quality of life measures in the maintenance aspect of the Crohn's trial, and as going alongside, obviously, its benefit in terms of clinical and endoscopic response and remission, you can see a clear signal of benefit that the drug improves patient quality of life. Then going on to the right of the slide, two slightly different ways of assessing fatigue. In ulcerative colitis, they used a combination of symptom relief and normalization of the fatigue score, and you can see again a signal of benefit both at induction in red, and maintenance in light blue compared to placebo. And in the Crohn's, they were looking, and that's the lower graph there, they were looking at patients who achieved a clinically meaningful improvement in fatigue. And again, they saw that at both induction and maintenance. Now, of course, what we don't know is whether the impact of drug on fatigue is purely a factor of its benefit in terms of disease activity, or whether in some way it has a separate role in terms of treating fatigue. And I guess that's going to be quite a complicated issue to tease out.
Fascinating, though. You know, I think COVID has, those of us who got fatigue related to COVID, I had appalling fatigue 48 hours after COVID, never felt anything like it. And now it's clearly physiological.
Yeah.
And so, you know, I think it taught me to be a little bit more sympathetic towards my patients. Anyway, I'm being told to get on with it. So I think we're going to move more towards ulcerative colitis now in relation to upadacitinib. And I think this is a really interesting question, and I'm sure one that many of us have thought about. And that is, in your patient who has been on tofacitinib and lost response, is it worthwhile having a go with upadacitinib? The logic, I guess, being that it's slightly different. It has a slightly more JAK1 selective profile to it than tofa. Likewise, one could apply the same logic to filgotinib, I suppose. And indeed, part of me wonders whether in some patients a less selective approach might be more effective. But so far, I think we've only got much in the way of convincing data in people going from tofacitinib to upadacitinib. So a couple of abstracts here, neither of which are spectacularly good, but both of which tell a similar story. The first is a multi-center study from the States, 11 centers, recruiting 100 patients, of which all of them, bar 2, had ulcerative colitis, and a third of them had been exposed to tofacitinib in the past. They looked at clinical response, which was a PGA, basically 50% reduction in symptoms, I think, and then clinical remission and endoscopic remission at later time points. Now, in fact, the results aren't on this slide for the tofacitinib cohort, but if you look at the bio-naive and tofacitinib cohort, then they tend to do better than the biologic exposed cohort. And in univariate analysis, prior exposure to tofacitinib was not a risk factor for failure of upadacitinib. So it didn't even go into multivariate analysis. But look, we're talking small numbers here. Nevertheless, if you look at the right-hand side, which is a single center study from Chicago, and now we really are looking at small numbers, 26 patients. But if you look actually at the outcomes in the table, it's fewer patients, because I think it's taken from the abstract, not from the presentation. But nevertheless, a proportion of them, in fact, the majority of them really seem to get a response, but only out to week 8. Does this ring true? Well, yes, it does to me. We've treated high single figures, I think, now of tofacitinib exposed and failed patients with upadacitinib, and all of them have had some response. But of course, that's a short follow-up, and I know that other centres have a similar experience. I don't know about you, James.
Yeah, and we have a very small experience, and in some people they've done well. And I think this is exactly, and we've talked about this at the London dinner, this is exactly somewhere where the UK is well positioned to collect a sort of nationwide survey of data, because we've had access to upadacitinib for UC and for Crohn's disease longer than most. Yeah. And I know that through the BSG, people are coordinating that, and obviously would encourage everyone to contribute to that if contacted.
Absolutely. Okay, another little clinical nugget. Many of you will have seen data about using tofacitinib as a rescue therapy in patients with acute severe colitis. We've published a cohort. Peter Higgins, I think, has published the biggest cohort, and this is a very similar study also from Peter Higgins, looking at high dose upadacitinib. That's 30 milligrams twice a day, of course, basically twice the usual dose in patients who have been admitted with acute severe ulcerative colitis. In the presentation, so it's different to the abstract. If you go back to look at the abstract, they presented 23 patients, most of whom had pancolitis, and in this cohort, a couple had had prior tofacitinib. Most of them had had prior advanced therapies, and they actually found, very similarly to the tofacitinib treated cohort, that they prevented colectomy in a reasonable proportion of patients. You're going to say exposure was short.
I'm going to say exposure was short, and also 30 BD is just a little. I mean, it's obviously it's not quite double the normal dose. It's 30 BD.
Oh, sorry, yes,
yeah,
double the
double the dose in. But I guess it was short, and of course, and I don't know whether they had previously had experience of 45 and decided to increase it to 60, or because obviously, you know, if you could get away with 45, that would feel safer to me. But of course, you know, they didn't. I think they had one episode of VTE within.
They did, and they had a couple of infections, and
of course, it's really difficult to know what was driving that risk of both infection and VTE. Was it drug or was it disease? And clearly, that's the kind of thing would only be answered by a proper trial, which I think is in.
Yeah, I think it's planned. Then it's not an easy trial to do this, not least because we're seeing far fewer patients with acute severe, actually, but still. But an interesting clinical nugget, and something we'll probably do more of over time. And then going back really to something that, excuse me, we talked about earlier, and that's I hate this de-escalation. It's reduction. Tofacitinib reduction can be considered in patients with endoscopic healing, is the title of the abstract, and it's looking at two different studies. Riveting, which we've mentioned before. So just to put riveting into context, this is patients who were in the original clinical trials for tofacitinib, and then they're in the open label extension. The way the trial is designed, the vast majority of people in the open label extension were on a majority dose. In other words, the majority of their time in the trial, they're on 10 BD, and most of them in the open label extension were still on 10 BD. Those patients who'd been on that dose for at least a good period of time, most of them through the maintenance, but some through open label for having failed at some point in the trial, were then randomized either to continuing 10 BD or going on to 5 BD. So it looks at those outcomes. I think we've already presented the 6-month data, and this is the final analysis now out to 30 months. And then there's also a real world cohort. I think this came from LA of about 80 patients with ulcerative colitis, and looking at their outcomes. So I'm going to summarize what this shows, and that is that when you continue following people up over time, a proportion of them relapse. And if you look at the top line here, out to 30 months, in the patients in riveting, in the 5 milligram BD dose, about half of patients remained in remission, and in the 10 BD dose, about 2/3 of patients remained in remission. That kind of makes sense to me. I think that's real. If you now subdivide them by what their endoscopic score was at the time of dose reduction, because they all had a scope at that point, patients with Mayo 0 generally did better than patients with Mayo 1. Again, I think that rings true, but overall the higher maintenance dose was a bit more effective. If you then pop down to the real world study, the UC flare rate at 12 months in the dose reduction group was about 50%, and in the dose maintenance group was about 50%, but fewer of them came into hospital. Again, a bit of context, we've just about finished a trial where we have dose reduced 50 patients with tofacitinib, and we're seeing about about a 50% flare rate over time. So what does this mean? Of course, if you think about the label, it tells us that we should be dose reducing. It's not on the slide here, but one of the things that did come out is the longer you were on the higher dose at induction, that was protective. Okay.
On dose reduction.
On dose reduction, yeah. And to my mind, when you follow these patients up over time, you see that 10 BD dose, and I can't say this yet for upadacitinib or filgotinib, but I believe, well, it doesn't matter with filgotinib because you can't dose reduce. Can't say it with upadacitinib yet, but I believe it. Some patients take quite a long time to get into a so-called deep remission, but that deep remission is worth achieving, and you're probably more likely to be able to dose reduce then.
Which I guess gives you a sort of feeling that certainly for UPA, where you've got a choice of 2 different maintenance doses, whether that you should maybe go down in stages.
Yeah, and in UC, Calpro is a really useful indicator here. We found. I'm not so sure about in Crohn's disease. Last of these studies I remember, tofacitinib and ustekinumab in the anti-TNF failed population. This was a multi-center study of 10 sites from France. They did, I think, propensity score matching here, although I think one has to be a little bit careful about propensity score matching because it's a variable feast, and we're not necessarily told which factors they match for, which factors they have just not been able to match for, and particularly in retrospective studies, I think one has to take all this with a pinch of salt. They did, however, have a pretty good cohort here, about 125 tofa patients and 165 ustekinumab patients, but they only really gave us results out to week 16. Which I think is of limited value, it has to be said.
Particularly with ustekinumab, where it might have a slightly longer, slow burn effect, whereas tofa is a short-acting, quick-acting drug. So it might be a little bit unfair on ustekinumab.
Absolutely, indeed. So basically, they didn't find much difference between the two overall. Although if you look over to the right-hand side, here they say predictors of ustekinumab failure would be primary failure of more than 1 biologic, exposure to more than 3 biologics. But I would take you straight back to James's point there. These are patients that take time, and I think probably tofa is going to have a better sort of short-term outlook there than long-term. Now let me just. There's some questions coming in. What I can't quite remember. There's another.
Yeah, there's another. Yeah.
Oh yes. Okay.
We've got the rest of small molecules.
So should we do? We'll do the rest of small molecules, then look at those. Then look at those. Then look at those abstracts. So patients with ulcerative colitis. This again is a post anti-TNF population, and this is comparing tofacitinib with vedolizumab, possibly at a better time point. That's week 52, and here we didn't have propensity score matching, as far as I remember. And you can see, if you look at the results here, about 70 patients with tofacitinib and 135 or so with vedolizumab. Let's just go straight to week 52 so that we take out that tofa works faster than vedolizumab almost certainly. There does appear to be a difference here in steroid-free clinical remission at week 52. 60% of the tofacitinib treated cohorts, 45% of the vedolizumab treated cohorts, reflected also by the endoscopic response. So this to me isn't particularly surprising, but of course they're likely to be very uneven cohorts, aren't they?
And it only just snuck into significance, didn't it?
Yeah.
I think.
One thing you could take away from this is both drugs are quite good, really.
Yeah.
So James.
So I'm going to go on to some of the data with the S1P modulators, and we've got a couple of abstracts on ozanimod and a couple on etrasimod. Ozanimod, obviously, we can currently use in ulcerative colitis, and I think one of the useful things to know in these kind of studies is what the long-term durability of treatment is, and obviously particularly with the small molecules where you would not be expecting any issue with immunogenicity because they don't develop anti-drug antibodies. It is quite interesting to see. So this is data from patients who went through the True North, which was the phase 3 trial, again a randomized responder at the end of induction into maintenance trial, but then entered the open label extension, and we've got about 130 patients who met the definition of response at the end of the clinical trial, went into the open label extension, obviously a single dose of ozanimod, and then looking at the outcome in terms, and here you can see in the sort of graph, we're looking at the mean endoscopic subscore, and you can see that they obviously improve with treatment during True North, and then the endoscopic disease activity remained flat through the week 94 of the open label extension. And then here on the right hand side, you've got the as observed, and of course that doesn't take into consideration patients who left the trial, and so it's a very generous definition, and you can see in light grey week 46 and in darker grey week 94, and then when you use the slightly half a definition, that if you dropped out of the trial you're assumed to have dropped out because of non-response, you can see the more traditional fall off that you would see, but again it shows that this is a drug that has some durability. Then I think very importantly, again, is looking at the longer term safety profile. There weren't any unduly concerning signals within the True North study. Don't forget that patients get a prompt and almost uniform lymphopenia because of the way that the drug works. It sequesters lymphocytes within the draining mesenteric lymph nodes. But within the True North study, there was not a real signal for increased risk of serious infections. I think there were a couple of cases of herpes zoster. There was a slight bradycardia, but no clinically meaningful adverse cardiac outcomes. And this then is looking at adverse events through the open label extension up to 3 years worth of treatment. So they've got just over 800 patients who'd been through to the open label extension week 94, and that was total patient years of exposure of 2,200 years, and the mean individual patient was exposed for just under 3 years. So it does give us a bit of a longer period to assess safety in patients, and we shouldn't be put off by the fact that 8 out of 10 experienced at least one treatment emergent adverse event, because that's the same across all studies, because any form of symptom is treated as an adverse event, including disease worsening and any form of biochemical or hematological abnormality. And as mentioned, of course, the most common was lymphopenia, because we know the drug causes lymphopenia. There were no trial discontinuations due to either bradycardia or adverse cardiac endpoints. And what you can see, and it isn't the easiest figure to read, but what we're looking at in grey are the most common adverse events, and as you can see, lymphopenia is right up there, nasopharyngitis, mild increase in liver function tests, COVID. These are the things you see in every clinical trial. Then we get into serious, and you can see the absolute level of infections is really very low, almost no malignancies reported, and adverse events of special interest. Again, I think that's one case of third degree heart block, one case of bradycardia.
I mean, I think the thing to take away about S1P receptor modulation is it's actually a very well tolerated class of drugs. If you speak to neurologists who've been using fingolimod and ozanimod for a long period of time, they all say it's really well tolerated. And I think, you know,
just got to get used to doing the ECG and then.
Right, but you know, doing an ECG is easy. And I think of it as a screening test. You know, but you want to know if your patient's got second or third degree heart block, whether they're having ozanimod or not.
And then we're going to go on to etrasimod, the phase 3 trials, which were the UC Elevate trials we presented last time. But what we're looking at here is the patients. We're looking at the steroid sparing effect. Now, importantly, this was a treat through design, so this was not a randomized responder. So we're looking at corticosteroid free remission, endoscopic improvement, and symptomatic remission. And what you can see is the drug clearly has a steroid sparing effect, as you would expect from its primary phase 3 data. And then here we're looking at histological remission alongside other endpoints, and again you can see a good maintenance of the histological and endoscopic endpoints. And again, and I'm not going to spend long, it's quite a wordy trial, wordy slide. There were absolutely no signals of safety compared to the ozanimod data. So it's a safe, as safe as that.
So we're just looking at some questions.
Let's do some questions, I think. So the first is a question very interesting about red meat and looking obviously about the association with red meat in terms of development of bowel cancer, and obviously when that comes alongside the risk associated with that we saw in the PREDICT study, does that increase the concern for eating meat in patients with ulcerative colitis? I think I come back to that they're both still associations, and I think we should be careful about making interventions.
And then actually we have a question which I think we brought up as well, which is mixing fish and meat together in the PREDICT analysis, because as pointed out, you can tell the difference in the food frequency questionnaires, and again highlighting the EPIC data. So totally agree. It's probably going to be a question best addressed to Charlie.
Yeah,
to be honest.
It wasn't discussed why they mixed meat and fish. I don't remember it being discussed in the presentation.
And then the next question is, did those receiving extended induction have no response at all? So this, I assume, relates to the UPA. So the answer is no. They didn't hit the bar of response as defined by the trial protocol. So, let's just give an example. I'll give an example for ulcerative colitis because it's easier. So if you're in a trial in UC and you start a drug, and then you go in and your rectal bleeding gets completely better, your diarrhea gets completely better, your endoscopy looks completely better, but you have one single tiny ulcer, and therefore you've got Mayo 3 colitis, by definition, you're a non-responder. Yeah. And I've chosen an extreme example there, but this is the problem with trials. It's inevitable that this happens, but it's the trouble with protocols that one has to adhere to.
And there's another question here, which I'm not quite sure what it refers to, but if it's about the Crohn's trial, patients in the upadacitinib Crohn's trial were not allowed to have been exposed.
No, I think it's about the patients I was talking about, patients who'd failed tofacitinib and then responded to upadacitinib. The question is, were they primary non-responders or secondary loss of response?
I see.
And I think it was a mixed cohort, but I couldn't say for sure. I have to say, in my experience, I think we've only really given it to patients who've had secondary loss of response.
And a question here about the selectivity of upadacitinib. As you know, theoretically, it's more selective to JAK1 inhibition, unlike tofacitinib, which has a broader selectivity. And the question is, does this explain why it might be more effective? And I think it's difficult to know. I mean, it may just be a simple dose thing. And of course, as the dose of upadacitinib increases, its selectivity decreases.
So next question, similar, UPA post failure of infliximab in acute severe UC. This is where we've had our experience, and I wouldn't say it was complete failure. It was people who were partial responders who we were having to give so much infliximab to keep them well that we realized we needed to do something else. To be honest, if I had a patient with acute severe who had completely no response at all to infliximab, I might be thinking more about surgery than about a second rescue therapy.
We've got lots of questions. We're just going to fire on a few more. Patients who are flaring after you've dose reduced tofacitinib to 5 milligrams. The question is, can you then escalate them to 10 milligram and keep them on 10 milligram consistently? And the answer to that is yes, you can. It's within the license and within the NICE approval.
What do you do if patients relapse following dose reduction of tofa? Same answer.
You increase the dose.
Have you found the initial dose monitoring required for ozanimod to be a barrier? It's not, I think probably not so much dose monitoring, but screening, as in doing an ECG, and in the very small proportion of patients that need it, getting an ophthalmologist to have a look in their eyes. So the answer is slightly, but it shouldn't be.
Next is a good question that I can't really answer, but I think it's a really important question, that if you've got a patient with a previous history of VTE and therefore they're already on lifelong anticoagulation. Are you concerned about using a JAK inhibitor in these patients? I think it's a really great question. I mean, the guideline from the EMEA would suggest that we should not be using JAK inhibitors in those patients unless they're the drug of last resort. But I tend to agree with the questioner that if they're already anticoagulated, I suspect the risk of a JAK inhibitor is lower. But I guess I would be cautious if there were alternatives.
So N equals 2 for me, I think. I've done it, and I saw someone today who I'm going to do it. Where do you see UPA fitting into our current treatment algorithm for UC or Crohn's in terms of choice of therapy, first, second line, etc.? Wow. Let's take cost into the equation there, because anti-TNF is very cheap, and I think that, it's a good drug in UC. So whilst I think it's certainly feasible and okay to use JAK inhibitors first line, and you got to remember a lot of patients do prefer tablets, I think most of the patients are going to end up being TNF.
And of course, the NICE approval in ulcerative colitis allows first-line use of upadacitinib, but if my memory is, the NICE approval for Crohn's disease is post-anti-TNF.
Correct. I think it's you, James.
No,
it's me. Okay, we'll do this quickly. So this is data regarding subcutaneous infliximab. There were 2 trials, Liberty Crohn's disease and Liberty UC, because the Americans wouldn't allow subcutaneous infliximab without a placebo-controlled study for reasons known only to the FDA. Not happy with the switch studies that allowed us to start using subcutaneous infliximab in the UK, and these are those studies, and the long and short of it is that they show, perhaps unsurprisingly, that after infliximab intravenous induction, this is true for Crohn's disease and UC, that ongoing maintenance with subcutaneous treatment is better than placebo. Surprise, surprise. I think the one thing that struck out to me here, and I'll take you down, look at the results section, and the bottom line here, anti-drug antibody rate 65% in the infliximab arm, so that's the subcut arm, 97% neutralizing, very similar in UC. This is not what we recognize as standard anti-drug antibodies.
No, this came up in the questioning. They were using an assay, and I now cannot remember the details, but we all agreed it was a different assay.
Right.
Because in fact, in our patients who we switch to subcutaneous, which is the vast majority of patients, we very rarely see anti-drug antibodies.
Right. Okay. And a switch, in fact, 2 switch studies here. One from the Spanish registered the ANIDA registry. One from Fraser Cummings, who's extending the pants, vest, undies theme by presenting swimsuit, which was patients switching from intravenous to subcutaneous. They didn't have to be in remission, interestingly, and he presented clinical and biochemical data and drug levels. I'm going to summarize this because we've got half an hour left and we've got a lot to get through, to say that overall, what we see obviously is drug levels go up when you switch from IV to subcut. That's because when you're giving IV infliximab, you're measuring a trough level. When you're testing it in patients having it 2 weekly, you're basically measuring steady state. The variation is small. So we don't really know what that means, and the immunogenicity is relatively low. That begs the question, do you need to carry on with azathioprine when you switch? But there's an RCT going on looking at that at the moment.
And I've got a couple of abstracts here. This was a data looking at the use of adalimumab, particularly at escalated dose adalimumab in patients with stricturing Crohn's disease. It came from Mike Cam in Australia. It was called Strident, and it took patients with symptomatic Crohn's disease strictures, and they had to have associated inflammation in terms of biomarkers or MRI evidence of inflammation, and the biomarkers obviously Calpro and CRP, and it randomized them 2-to-1 to high dose adalimumab, which was 160 milligram weekly for 4 weeks, followed by every other week with combo therapy and a thiopurine, and the dose escalated back to weekly if there was any evidence of ongoing inflammation. So that's quite escalated dose adalimumab compared to standard 160, 80, 40 milligram every other week. Now, the primary endpoint of this trial was the obstructive symptom score, which effectively was a non-validated score based around abdominal pain. And what you can actually see is the trial did not meet its primary endpoint. It was not more effective to use escalated dose adalimumab, perhaps numerically more here in the primary endpoint, steroid-free improvement, but not significantly so. But what you did see was that the escalated dosing was associated with some objective improvement in terms of the degree of inflammation. And I wonder whether that just reflects the fact that some of these patients, their symptoms were driven by the fibrotic aspects of their strictures, right, rather than the inflammatory. And what they showed, and this is obviously not surprising, is that if you responded clinically, you were less likely to require surgery. And of course, that simply reflects the fact that we don't tend to operate on patients with no symptoms. The next, I think, is a really interesting trial, not because of the message that it was purported to give, but because actually you often need to look down into the details of a trial in order to work out what it's actually saying. It was a trial in pediatrics, and it was effectively looking to see whether if you had patients on either adalimumab or infliximab, whether you needed to use methotrexate as combination therapy to improve persistence on treatment. So the primary outcome was treatment failure. The important sentences here is the anti-TNF dosing was managed at the discretion of the clinician. And what they did is they took a group of kids with Crohn's disease, naive to biologics, no contraindication to methotrexate. They started them on the anti-TNF, and then they either randomized them to methotrexate or placebo and then followed them up. They included just under 300 patients, the majority receiving infliximab, and as you can see, the randomization split them 50-50 into combo therapy versus monotherapy. And what they showed is that if you were on infliximab, the addition of methotrexate did not seem to have a benefit, whereas if you were on adalimumab, you can see that methotrexate seemed to make a significant difference. And from this, they concluded that adalimumab required methotrexate and infliximab did not. But to some extent, that's a slightly spurious conclusion because of the sentence here. Anti-TNF was managed at the discretion of the clinician. And patients on infliximab had significantly more office visits, significantly more drug levels measured, and were significantly more likely to escalate dose. So I guess if you can't escalate your dose of drug, then perhaps you do need a combination with methotrexate. And I think we have to be a little bit careful about how we interpret data like that.
Just published in Gastroenterology, we hear.
Yeah.
Somewhat surprisingly, I think.
The next is a really interesting study, and it's something that we've been wondering about for some time. And it's looking to see whether if you've got a patient who initially responded to ustekinumab treatment in Crohn's disease, so they went on to sub-Q 8-weekly maintenance, and then they lose that response, can you recapture the response by giving them another IV 6 milligram per kilogram dose? And so this was the POWER trial, taking patients who had been well on ustekinumab, who subsequently had a flare defined as an increase in disease activity plus a biomarker of inflammation, and then randomizing them to either receive an IV reinduction dose or continue with 8-weekly ustekinumab and then follow them up over time. And what you can see here is the primary endpoint was here at week 16. So after effectively 2 doses of sub-Q, or 1 IV dose and 1 sub-Q dose. And if you cut across to the middle and the right of the slide, what you can actually see is that that IV dose did not seem to have a significant benefit in terms of short or medium term response over and above continuing 8-weekly treatment. For me, what I think was a real shame is that actually here, what you see is they effectively just substituted a scheduled 8-weekly dose with the IV dose. And I think what might have been interesting would be to have had an additional IV dose and then continue with the scheduled 90 milligram sub-Q doses, because effectively you're talking about giving them a bit more ustekinumab, not a lot more ustekinumab. And also I suspect week 16 may be too early an on point to see any difference.
There was actually an abstract that looked at IV and then Q4 as opposed to Q8. It wasn't of the quality of this, but it suggested that you got more benefit from that.
You've got the thiopurine trial.
Oh, this is fantastic. Really interesting question is, if you've got a patient who's on azathioprine and then they're also on vedolizumab, should you stop the azathioprine? And I think my gut feeling here has always been yes.
Stop the azathioprine.
Stop the azathioprine,
That's what we tend to
mostly because of the lack of immunogenicity
and the gut selective nature of vedolizumab, meaning that you can't really, you may not need that the immunomodulator and the safety risks associated with it.
I think the safety thing is a really big thing, isn't it? Anyway. So I think it was an Aussie study again, wasn't it? An Australian study in which they took people who'd been on Vedo and a thiopurine for more than 6 months. They're in steroid-free remission for that amount of time at least as well. Randomised them 2-to-1 to withdraw or continue. The primary outcome note was drug levels at week 48, and secondary outcomes: disease relapse, secondary red, endoscopic remission, etc., etc., etc. 62 patients, so relatively small. 42 withdrew, 20 to continue, and you can see along the bottom there, blue is continue, pink is withdraw. Now, they've probably been a little bit naughty here, in that if the primary outcome is trough levels over on the right-hand side, and they're no different, then to start doing p-values on secondary outcomes on which the study isn't powered is perhaps not entirely valid. But let's ignore that and let's look at the patterns here. And I think that's fair enough, really, isn't it? And if you look at remission, if you look at the biomarkers, that's Calpro, CRP. If you look at endoscopy, if you look at histology and histoendoscopic remission, not surprisingly, you put them all together, withdrawal seems to do worse than carrying on of azathioprine. And that, to me, in some way, I mean, it does ring true. Azathioprine works in ulcerative colitis.
Yeah, I mean, the original Barney Hawthorne withdrawal trials showed that if you withdraw azathioprine, patients are more likely to flare.
Right.
And of course, what you don't know about this cohort of patients, because these were a group of patients who had been on combo therapy for a period of time, were they patients with a more severe disease phenotype than we normally see? And why were they on combination therapy for that period of time, given that standard practice is to withdraw azathioprine?
I think, and the other thing is, of course, that whenever you put people into withdrawal studies, sometimes you get a biased cohort because people don't put in the patients they're worried about relapse. So that perhaps makes this even more interesting. This is a study, in fact, many of you will have seen at ECHO. It's a collaborative study from AMC and other centres, and it looks at post-operative vedolizumab in patients who've had an ileocecal resection. 80 patients overall, and the primary outcome was endoscopic recurrence of Crohn's disease at 6 months. Now, James and I slightly disagree on this because I think this is a valid endpoint and you're not so convinced by it. Anyway, let's look at the results here. And you can see perhaps most easily on the graph at the bottom right-hand side of the slide there, that the vedolizumab patients were more likely to have basically I0 and I1 if you group them together, and they were less likely to have I3 and I4 recurrence than the patients who were given placebo. Again, not hugely surprising to me, just a couple of little quirks of the study. So they didn't give 0 to 6, they just all went on to 8 weekly. Right from the start. I think I wouldn't have done that, but fair enough. And I think, James, I know you're less convinced about endoscopic endpoints, but I think in this context, I think you can extrapolate. But still, go ahead.
Well, no. I mean, the point being, obviously, the Root score is a predictive score, not designed as an endpoint. And what we need to know from studies like this, and of course, the data may come out, is looking at subsequent clinical recurrence.
Yeah, but the difficulty with that is how long do you have to wait?
Well,
that's why but the topic was negative.
In the subgroup of patients that smoked, azathioprine had
sub-analysis. Yeah. And then another extended induction study, this time with risankizumab, an anti-P19 antibody, looking at patients with Crohn's disease. Of course, this is relevant because risankizumab is now NICE approved in patients with Crohn's disease who have failed anti-TNF therapy, although I think there's some difficulty with access to the drug at the moment because of the lack of the on-body injector. But coming soon, many of us have quite a lot of patients in the patient access scheme, which AbbVie were very good at setting up, it has to be said. Anyway, this is looking at patients with non-response at week 12. And again, I take you exactly back to the comments I made before about thinking a little bit carefully about what one means by non-response. Those patients in the trial were then allowed an additional 12 weeks of risankizumab. In fact, this was a case right back in phase 2 as well.
Yeah.
That happened in phase 2 as well. And again, as with pretty much all such studies, you see about half of patients, or slightly more in some, depending on what outcome you're looking at, but about half of patients seem to benefit from extended induction if you're looking at the harder endpoints like remission. And importantly, if you then look at how they do in maintenance, actually those late responders tend to do quite well as well.
And I think we see that from the risankizumab experience. If you do well either early or over an extended induction period, you tend to maintain that benefit.
And I wouldn't limit that to risankizumab.
No,
I think that's Crohn's disease.
Yeah, and I'm going to show exactly the same thing here with mirikizumab and ulcerative colitis. So mirikizumab is going to be the first anti-P19 that we have available for ulcerative colitis towards the end of this year or middle of this year, and this is then looking at patients who received the standard induction dosing of Miri, which is 300 milligrams 4 weekly to week 12, and then they go down to a maintenance dose, which is 200 milligram 8 weekly. But in this patient, the non-responders received an ongoing 300 milligram for a further 3 doses. And what you can see, as we've seen many times before, about half achieve clinical response, slightly fewer with the harder endpoints. So much as we've seen before. Then some interesting data from the phase 3 trials of mirikizumab in ulcerative colitis. These were the Lucent trials. Lucent 1 was induction, Lucent 2 was maintenance. And what this is looking across a range of different endpoints. So at top is clinical remission, clinical response in purple, symptomatic remission in green, endoscopic remission in sort of red. And it's then looking to see whether previous treatments impact the significance of the number of patients who achieve those endpoints with drug compared to placebo. And this left-hand figure is looking at induction, the right-hand figure is looking at maintenance. And what you can see, let's take the clinical responses, looking at the numbers of prior biologic failures. You do see a slight dropping off of significance with the harder endpoint of clinical remission. But when you look at induction, at response or symptomatic remission, or actually endoscopic remission for that matter, that you seem to see benefit irrespective of the prior number of previous biologics, or whether it was an anti-TNF and a thiopurine and a JAK inhibitor, an anti-TNF or vedolizumab. And you can see here that when you get to the maintenance, that irrespective of prior exposure, drug is better than placebo. One of the key parts of the Lucent trial design has been the assessment of bowel urgency. They've developed a bowel urgency rating score, 0 to 10, and they define remission as a fall to 0, 1, or 2, and they also looked at fatigue. They did bowel urgency remission is as a fall to 0 or 1, and they also looked at fatigue. And what they're looking at here is what's called a mediation analysis, and so they're looking to see whether they can find out what percentage of the change of the change of fatigue was associated with the bowel urgency remission compared to remission in other areas such as rectal bleeding or stool frequency. And on the left here, what you can see is that actually the significant improvement of that you saw with drug in terms of fatigue was predominantly associated with a reduction in bowel urgency and not a reduction in rectal bleeding or stool frequency, and the same with a different definition of fatigue.
Okay, I'm going to do this very quickly. A, because we've already seen this at Echo. B, because it's phase 2. Tis interesting. It is a study of a new biologic which is an antibody to TL1A, anti-TNF like ligand 1A, and this was a study in moderate to severe UC. I'm not going to show you any more on this study other than to say outcome was week 12. And you can see endoscopy was obviously performed then. And you can see, look over at the left-hand side here, here's the primary endpoint, clinical remission, 26.5 versus 1.5 placebo, unbelievable. And this was mirrored both with endoscopic improvement and endoscopic response. And then I'm going to take you over to the right-hand side because there was a diagnostic associated with this as well, which was basically a genetic marker, which I think only occurred in about a quarter of patients. Yeah. But look over on the right here. Ignore the large error bars. Oops. But there's a signal here that the drug may work better in the patients who have this marker for response. Let's not go into this anymore. It's phase 2. We are going to see more data here. Phase 3 is up and running. And there are other TLA agonists already in development. Okay, some more questions. So JAK inhibitors and proctitis. So patients with proctitis were included in some of the JAK inhibitor trials, but the number of them was so small that it's difficult to assess them separately as a subgroup. Yeah, I agree. But in general, I would say proctitis I treat just as ulcerative colitis overall. Those of people in bio-experienced patients with Crohn's, I would go for the higher maintenance dose, at least initially.
So this is, I expect, referring to the Liberty trials, where the patients were fistulizing Crohn's disease, and
yeah,
I'm not going to be able to answer.
It's a good question. Don't know the answer to it. I suspect there would have been, but I don't know. I don't think they presented those outcomes.
I think this must be referring to your vedolizumab post-op data. What do you mean by immediately after surgery?
Okay, so pass. I'm sure it wasn't exactly the day after surgery. And I would suggest that it probably doesn't matter that much. But in clinical practice, once people are feeling better and the surgeons are happy, there's no sepsis, we're happy to go for it. That's a long question. Are you reading it?
Well, I was in the vedolizumab post-op prevention study. The baseline Calpro had a high IQR, 4 to 1800. Was it actually that some of these patients had active disease? And I guess the trouble here is that I'm not sure I know what the time course of Calpro is after surgery, and I honestly just don't know the answer to that. I mean,
but it would be surprising if you didn't get some
peak of Calpro after surgery. I have to be honest, Richard, I don't know the answer to that. We're sort of running out of time, and I think we're therefore going to just select some highlights of the next. We're not going to do that one. We're not going to do that one.
Oh, we've got to do this one. It's my favorite. These are my favorite abstracts. So top left here, this is AI. There are a couple of abstracts about this actually, using pictures of the poo in the toilet to predict endoscopic outcome. And it was actually quite accurate, as you can see there, with an area under the curve of 0.8. So people hopefully will no longer be bringing pictures of poo to show us on their phone, but in fact they'll be getting their pictures of poo and they'll be telling us how bad their endoscopy is.
How do we know that's just not detecting blood? Because blood is a very good marker of endoscopic disease activity, and it correlates with the presence of rectal bleeding. And maybe it's not, I don't know if I know how granular it is, but obviously you could imagine that it's easier to detect blood or no blood. That's
you see, you're a Luddite. You wait and see. And then the other favourite one was bottom left. This is something that they'd invented at MIT, which is a box that you put on your wall in your house, and it collects data on your sleep, your breathing, and how much you're walking around, and it could identify flares and remission before they were clinically apparent. So soon our patients will simply be sticking a box on their wall and it'll start beeping when they're about to relapse.
It won't require them to do fecal calprotectin. And we're gonna move on. Okay, so just to highlight, and we are moving forward because we're running out of time, but all the abstracts are in the handout, which you can download, so you don't have to rely on us going through them with you. I'm just going to do this study because I think it's really interesting, and it backs up data that we've seen before from the LYRIC trial, which was looking at the LYRIC trial was a randomized controlled trial looking at primary laparoscopic resection versus anti-TNF in people with limited ileocolic disease. Quality of life as the primary endpoint, no significant difference between interventions, but if you follow people up over time, the majority of people who received, over 50% of people who underwent surgery did not need subsequent treatment, whereas a good proportion of those who were treated with an anti-TNF did subsequently require surgery. So this was looking at the same question in a very different way, using a Danish database registry and comparing patients with an index diagnosis of ileal or ileocecal Crohn's disease over a time window, and then looking to those who had an early ileocecal resection, which was about 500, or who commenced an anti-TNF, which was about 700, between 1 month and 1 year after diagnosis, and then looking in the subsequent years for a composite of some of the following: a Crohn's disease-related hospitalization, the diagnosis of perianal disease, requirement for steroids or surgery. And what you can see here is that the composite endpoint, disease complications, as it were, was more likely to be reached in those treated with an anti-TNF than in those who underwent surgery. Although, of course, by definition, all of those who underwent surgery had already had surgery. So we're talking about second surgery versus first surgery. I mean, it may be sort of, obvious.
Okay, just going to show you another surgical study, and it's nice to see some high quality. You're going to do one more after this. Some high quality surgical studies coming through, and this is a randomized controlled trial. Now, not blinded, single center, but 120 patients who were randomized to have either CONO-S anastomosis post ileocolonic resection, or a conventional side to side, and when they looked at recurrence on multivariate analysis, CONO-S was the only variable that was associated with recurrence, and you can see quite an impressive odds ratio there. 0.25, 75% reduction. So interesting, not necessarily the end of the story, I think it's fair to say.
These are two studies, two single center experiences that have suggested or supported the use of the CONO-S anastomosis. And obviously the UK European MEERKAT trial, which is a multi-center study, will be perhaps a more objective assessment.
I think there's another problem with this though, and that is that, and it goes really back to the Rutgers score, and endoscopic recurrence and things like that. We don't know what that means in a CONO-S, and we're not used to looking at CONO-S's yet. And different anastomoses.
Yeah, well, a CONO-S obviously is a hand-sewn anastomosis, so you're less likely to get an ulcer. But I think these data remain significant if you took out I2A as a definition of endoscopic recurrence, which is those anastomotic ulcers that we're not quite sure what they mean. So,
indeed.
But yeah, and which was the last one you wanted me to do? Yes. And this is actually not a very good quality abstract, but I think it's a really interesting point, and it's very relevant as we use more and more small molecules. And it was a study looking at the prevalence of high-grade squamous intraepithelial neoplasia and anal cancer in gay men who had inflammatory bowel disease. And as I say, it's not a particularly good quality study because it used as its identification patients who had been referred to an anal cancer screening clinic. And there were some high-risk groups who were more likely to be referred to an anal screening clinic. But effectively, what it's telling us is something that I certainly, up until recently, when I had a case of a patient who did have intraepithelial anal neoplasia, and I hadn't really thought of, is actually thinking about whether our patients are at risk of developing HPV of the anus, and knowing where our local anoscopy, high resolution anoscopy center is, so that particularly people who are at high risk, who are HIV positive, or patients who have anal sex, and that doesn't have to be men who have sex with men, it can be anyone who has anal sex, thinking about whether they are at risk, and if they are, particularly if they have a previous history of warts, to consider referring for screening, particularly with some of the newer small molecules.
Yeah, it's really relevant, and it's an easy win.
Yeah. But we've spoken a lot about small molecules, the JAK inhibitors and the S1Ps. We've spoken about the sub-Q infliximab, the anti-P19s, which will be coming through in the very, very near future. And then obviously some treatments on surgery and stricture therapy. And I think, if I'm right, that then is the end. Yeah, so we're just going to finish here and say again, thank you to AbbVie, Bristol Myers Squibb, Celltrion, Galapagos, Pfizer, and Takeda. I think we are out of slides. So thank you very much indeed for being with us on a Tuesday night.
Thank you, and hopefully see you again for Best of UEGW and ACG sometime towards the end of the year.
And thank you again to Debbie and the Cornerstones team who worked so hard to put this together.
Good night.